world-renowned pain specialist Dr. Winston Parris has been chosen to lead an effort to establish the first ever pain management center in Viet Nam. Dr. Winston Parris is the Professor Emeritus in the Department of Anesthesiology at Duke University Medical Center. He has been invited to help develop a comprehensive pain management center at Cho Ray Teaching Hospital in Ho Chi Minh City, Viet Nam. The facility will be the first of its kind in Vietnam and will also be involved in clinical research. The Cho Ray Teaching Hospital is a 10,000-bed hospital and is one of the largest and most advanced hospitals in Vietnam. Dr. Parris leaves St. Lucia within a few days for Ho Chi Minh City in Vietnam. This is The Reality Show on Calabash TV.
Doc, we want to welcome you to Calabash TV. I think we have spoken with you, but it's the first time to our studios.
Yes, thank you.
So it's certainly very good to have you here. And this comes at a very a big moment for St. Lucia and for you as well. You're leaving the island shortly to head to Vietnam. And we were speaking just off camera that you've been there before, so you're familiar with the territory.
Yes, I am.
But before we actually get to that, we want to thank you, first of all, for the work you did over the past couple of years, honoring a St. Lucian, the Impolite, who is richly deserving of that recognition. And we were very happy to interact with you as well,
yes,
to be able to honor one of our great Governor Generals. We want to thank you as well for that opportunity.
My pleasure.
Now, let's talk a little bit about Vietnam. I'm sure, we hear the stories of Vietnam and we think of the US and we think of war and so on. Talk to us about your very first visit to Vietnam. What was your anticipation, your expectation, first of all, and what was the experience?
My first visit to Vietnam was in June last year. I took a vacation to the Far East, and I have a son. My first son, Wayne, works in Vietnam. He has a company. In fact, he's now a permanent resident in Vietnam. He, by specialty, what is he? He did political science, and he worked in the Congress, in the United States Congress. He was an aide to Senator Fred Thompson. But I guess he wanted something different, and he went over to Vietnam about 5 years ago, and was having difficulty sort of getting what he wanted done. You know, the wheels of it's still a communist country, but a delightful communist country. But the wheels of the bureaucracy turned a little slowly, and he had to make a living. So he started teaching English, and realized that that's a big business, and everybody in Vietnam wants his kid to be able to speak English. So he developed that and was doing well at it. He has his own company now. And so he invited us. In fact, we went with the Destangs, the Joyce and Desmond, and my wife and I, and four of us went there. And we had a delightful 2 weeks, and it's a beautiful place. What we discovered was that although there was a horrible war, and I did go to the War Museum, it was a horrible war. But one of the good things is that 80% of the population of Vietnam is under 50. So they have no recollection of the atrocities of the wars. And they love Americans out there, and they love people in general. So while I was there, one of his friends, who was a professor in the university, invited me to give a talk to the Department of Anesthesiology at the Cho Ray Medical Center. And I did, and I thought I was going to talk to about 1 or 2 dozen people, and about 300 physicians turned up to hear the talk, and I guess they liked it, and one thing led to another, and the authorities got together with me, and they want me to help them develop a multidisciplinary pain center in Ho Chi Minh City, which is the capital. It used to be called Saigon, but it's now Ho Chi Minh City. And this is a huge facility. It's 10,000 beds, and it works very efficiently. It's a tremendous model for delivery. It's not a Harvard Medical Center or Duke Medical Center, but it gets the job done. It's efficient, it's clean, and it's functional.
But actually, as a doc, a 10,000 bed facility, how intimidating is that?
Well, it works well. The organization is quite smooth and efficient, you know, the service is done. People, there are no very long lines. It's I guess I didn't visit the hospital. I just came to give the talk in the auditorium, actually just outside the operating room. And I didn't go into the details of the mechanisms of the hospital. But from my superficial observation, it looks very efficient. And people were pleasant, and people were delightful. People were receiving their care, and there were no extremely long lines. And so it looked like it was efficient.
So what would be your responsibility? You were leading the efforts to establish that pain management center. What exactly would be your responsibility?
Yes. Well, as you know, pain is a relatively new specialty. Pain is taken for granted. But as the old philosopher John Dryden said, for all the happiness mankind can gain, it is not in pleasure, but in freedom from pain. So now people are recognizing this is an important component in the delivery of healthcare. And so to get it organized and to recognize that there are so many technical, pharmacological, and systemic components to the delivery of healthcare for pain management, they want to address that. There was a section in their cancer center where they were actually dispensing adequate opioid medication. But there's more you can do for cancer pain. For example, if you have a cancer of the pancreas, there's a procedure called a celiac plexus block, which can effectively control the pain. You're still going to die, but it stops the pain, and you don't have to take the large doses of opioids, which means you're able to interact more intimately and more effectively with your loved ones, and that's a big deal. So to get that done and to use all the other modalities for back pain, for migraine, for chest pain, for perineal pain, for leg pain, there are many other what we call sympathetic nervous system syndromes, where there are some specific procedures, injections you can do. This is what I'm bringing to the table. So to that end, they have identified the doctor who is going to lead it is a Dr. Viet Nam. And he is coming over. First of all, I've been giving him textbooks to read. We've been doing this for the past 6 months, and he's very bright, and he's picking it up very quickly. So the next step is I go over there, and we work out with the authorities what I want, how I want it, and what is the personnel that's going to be needed to run it. Then I take him over to the States with me for 1 month. He spends one week with me. I send him to the Duke Clinic for 1 week. I send him to the Yale Clinic for 1 week, and I send him to the University of Mississippi in Jackson for 1 week. I have fellows who I trained in those centers, and it wouldn't cost him anything. He'll stay with them, and he'll watch their operations. So he will pick up that there's no one way to skin a cat, and he will get that experience. So when he goes back to Ho Chi Minh City, he can work out what's best for them in Ho Chi Minh City. Every system, you know, everybody makes their coffee differently. And so he will work out what's best for him. And so I will be there in the first instance for about 10 days to 2 weeks to work out the formalities. Then I'll go back next year when the clinic is formally opened and spend about 3 months with them. I'm going this time by myself, but when I go for 3 months, I'll take my wife with me. Ironically, the university has been scouted where my son lives, so they got a condo in that same unit. So at least I'll be close to him, but not in his space. So I'll be there for about 3 months.
What's involved in a pain management center? Are there specialized equipment that goes with it, or is it just the knowledge and how you apply it?
All of the above. There is specialized knowledge. First of all, we are now discovering that what we used to call pain was a little different. I'll give you a classic example. I have an uncle. I was a young doctor here in 1971, and this gentleman used to tell me, Winnie, he called me Winnie, my legs are hurting me, and I couldn't find anything wrong with him. And that was in 1971, and we got everybody to see him. Couldn't find it. It turns out he had bad diabetes, and diabetes affects the nerves because of the high blood sugar content. It's like rust of your wires. So the high sugar causes degeneration and damage to the coverings of the nerves, and that causes what we call diabetic neuropathy pain. Opioids don't treat that. There are some specific injections called lumbar sympathetic blocks or stellate ganglion blocks, specialized blocks of the central nervous system, the sympathetic part of the nervous system, that you can do, and that stops the pain. And there are some drugs which we call anti-epileptic drugs like Lyrica, gabapentin. These drugs can be used to help. So that's a specific knowledge. Another thing is you have to look at pain like the way you look at electricity. You have a bulb that is flickering. You change the bulb, it still flickers. There is a short in your system. Now you can do everything unless you correct that short. So you have to look at pain in that kind of model. And there are certain diseases that cause shorts. I use shorts in parentheses, interruptions. There are certain diseases that cause those interruptions, which causes pain. When you understand that, you diagnose it. There are certain specific treatments. You can get into the nervous system. You can get into the base of the brain. These are very sensitive procedures. So you need a special machine called a fluoroscopic machine, or C-arm it is called. You can see where your needle is at all times. You can inject dye so you can see where the dye is, a liquid stuff which you can see under the x-ray, and you can see where your needle is, and so your injection is precise. And there are certain tubes we can put in the spinal cord which delivers small amounts of concentrated opioids which are enough to stop the pain without creating side effects. For example, if let's say you have a bad chest pain from a cancer and you take 30 milligrams of morphine 4 times a day to control your pain, I can get into your thoracic spine and give you about 0.5, which doesn't give you many side, and it stops the pain. So these are some of the techniques you use. When you look at back pain, which is probably the most common pain, it costs the United States billions of dollars per year, because from lost work, lost wages, lost tax and structure. When you can block the pain, for example, the pain could be due to a bulging disc or degenerated facets or pressure on the nerve root as it comes out from the spinal cord. And these things happen with age. These things happen the result of athletic injuries. These things happen as a result just of degenerative changes. Or another common one is what we call scoliosis. Not everybody has a perfectly straight spine. In fact, nobody has a perfectly straight spine. But because they have mild deviations, the injuries we sustain with jumping out of trees, high jumping, during childhood, by the time you get to middle age and old age, the degenerative changes takes place, and that causes pressure on the exiting nerve roots. And that, if you can identify that, and thank goodness we have things like the MRI that can tell us especially what the lesion is, you can go into those areas and inject them. And it may not take away all the pain, but it certainly helps to manage it and to control it. And of course, we are developing new drugs all the time, which are safe and relatively complication-free, which can control that. So that is what pain management is involved. And another thing is that, let's assume you have a bad knee, and you come and tell me, geez, you're being fired from your job. Guess what? Your knee pain gets worse. What has happened because of the depression associated with your about to be fired? There are certain things like serotonin, norepinephrine that are released from the brain as a result of depression. These act like gasoline on nerves and they cause more pain. So all the treatment I can give you, if we don't address the depression associated with your problem. So that's what I mean by multidisciplinary. No, there's an old saying, when you have a hammer, everything looks like a nail. In pain, not everything requires an injection, not everything requires a pill. So that's why evaluation and assessment is critical.
Now you mentioned back pain and also pain from cancer. I would imagine from what you said that there's more cases of back pain than cancer, but would be, as somebody who's specializing in pain management, which one is the most challenging?
That's a difficult question. It depends on the individual case. I've had some patients with cancer that are straightforward. Some cases with back pain. No back pain is going to kill you, but it can be irritating. Let me make sure I can remember. They're what we call the clinical features of chronic pain. One, depression. If you can't lift up your children, if you can't swim, you can't play tennis, you can't do the things you always do, you get depressed. There's disuse. Because of the pain, you do not use the back, so degenerative changes take place. If you park a car and you don't use it every day, degenerative things are going to happen. So there is dependency. When you when you have chronic back pain, you become dependent on other persons, or you become dependent on the system. If you get a check, be it from whatever agency, you could become dependent on that check. So you lose your independency. And then there is disability. You become disabled. Then there is doctor shopping. You go to Doctor A, you're not better. You go to Doctor B. Before you know it, you've seen a bunch of doctors get a lot of medicines, and that brings about drug addiction. So there's a complex of things which come. There's a case of this guy, a good friend of mine, who his wife had a back problem, so he didn't play golf with me. He stayed home with her that weekend, and she liked that. So she was better. And so next weekend he said he was going to play the back pain game. So that is part of the dependency syndrome. So it requires a trained professional to understand that and to try to restore the independence for the patient, to recognize that as we get older, there are going to be changes in our lives, but it's not the end of the world, and you can function. And
recently, and we heard all the time that especially sports personalities who are on pain medication. I think recently Ralph Nadal mentioned that he's been on pain medication for a very long time, for the past couple of years, and we've heard of superstars as well in terms of the arts and so on who are dependent. We mentioned, I think, dependence a while ago on pain medication. How worried should we be? Because sometimes they're over-the-counter things. What are the things that would you advise on when you get pain? What exactly is the next step?
As you bring up that topic, that brings about something that makes my pressure go up just a little bit. Because you may recall in the end of the 90s, to be exact, in 1994, I was the president of the American Board of Pain Medicine. And we set out a series of policies which people should have followed. But bureaucracies and politics set in, and they didn't follow everything. A lot of them were followed, but one thing they didn't follow is that I recommended, or my team recommended, that the persons treating pain, just like the persons doing brain surgery should be board-certified neurosurgeons, persons doing pain should be board-certified pain specialists. That was not followed. So the pharmaceutical companies, in their greed or showed their aggressive business acumen, they marketed opioids to everybody. And they didn't tell the truth by stating that there were certain bad things that could happen with opioids. They gave the impression that anybody could write a prescription for morphine, and people did, and that's why we have the big opioid crisis today. They gave pharmacologically, they said there was a ceiling effect. What that meant in pharmacological terms, when you reach a certain level, you couldn't do any more harm. That was wrong. That was a quirk, and that was wrong. So, but they gave the impression that there was safety in those drugs. If you're not aware of the fact that you can get dependency, you can get addiction, you can get respiratory depression, that's what kills people. The opioids act on the brain. It's a central nervous system depression, and it decreases the respiratory function of the respiratory center, so that you give a patient a bunch of opioids, they go to bed, they don't wake up, and that people are dying in their car. And on top of that, people crave it. It has what is called a euphoric effect. And if you give the Pope a bunch of opioids, guess what? He would beg, steal, do what it takes to get it. It has nothing to do with your character. I run an addiction clinic in the U.S. for some patients who have addiction problems, and they do not want to go to the regular clinics, so it's sort of a private clinic. And these are doctors, lawyers, CEOs, priests, a lot of people. And I'll give another example. I had a neighbor who had neck surgery, And I was getting ready to travel, so I went to see him. I said, "Hey, how you doing?" He said, "It's fine." I said, "How was your pain?" He said, "Not much." "Did they give you any pain medicine?" They gave him 200 pills to take one every 4 hours. That was irresponsible, and that was from a university center. I'm not calling names. If this guy had taken these opioids one every 4 hours, at the end of it, he would be addicted. So he'd go to his doctor, not complain. His brain would tell him he has pain, although the pain is long gone. But that's part of the addiction, and he would be craving the opioids. And when the doctor would recognize after 3, 4, 5 months that this guy is addicted, he would cut him off. What would he do? He'd go on the streets and buy it. And that's how the problem was compound itself. And it's a big, whereas if they had followed that initial advice, which we had proposed in 1994, it was painful, but that was the right thing. It wasn't done, and that's why we're dealing with the opioid crisis today.
I wanted to ask you just a couple more questions in terms of, before I even get to that, in terms of how did you get, first of all, interested in it? Because I'm sure there were so many other options that you had, the regular mainstream professions in medicine to go to, but you decided to focus exclusively on pain management. What exactly inspired that?
Well, I didn't focus exactly on pain. I am, my primary specialty is anesthesiology. A lot of my early research was done on anesthesiology. Anesthesiology is the science involved in putting people to sleep, and I would like to add, and waking them up safely. And that is pretty complicated in the sense that you have to care about the circulation, because as the surgeon is cutting, he's losing blood, you have to monitor that and replace it appropriately. When you're dealing with an old elderly patient, you can't give them too much blood or too much fluids, because you put them in pulmonary edema and they die from circulatory overload. You have to watch about the effects on the kidneys, the effects on the lungs. So and in addition to putting people to sleep so that they don't they're not aware of what's going on and they don't feel pain, you also have to relax the muscles. When a surgeon is cutting into your abdomen, there are many muscles. If these muscles are in spasm or tense, he can't do the job effectively. So the art of using muscle relaxants is a very important thing. And all those drugs have side effects which you have to anticipate. And the drugs you use to create relaxation to cause amnesia, you have to reverse it. So all this is complicated. So while I was doing this, I started doing anesthesia, my goodness, from 1970. And I came here to St. Lucia. I was the only anesthetist for 4.5 years. And we were able to anesthetize everything that came to us. And I think we had a good run. We didn't have many casualties, if any. But when I went to the U.S. and I sort of did advanced training in anesthesia, I was at Vanderbilt University, I noticed that there were patients who were coming back for a third and a fourth and a fifth and even an eighth back surgery. So I said, what is this? If the surgeon is removing a bulging disc or correcting a degenerative organ, why is the patient coming back with more pain? And it occurred to me that was a failure. Not necessarily the surgery didn't fail, but the recommendation of the surgery in the first place was a wrong approach. I'll give you an example of what I mean by that. If you were eating a hamburger and a piece of some ketchup, a blob of ketchup, which is red, would fall on your nice white shirt, if you leave it alone, you just have a red spot. But if you try to clean it, you have a large stuff. What I'm leading up to, you have a bulging disc. You remove that disc. But the reason why you have a bulge in the first place is there is accumulation of scar tissue. You have a tendency to form scar tissue. You go and you remove that scar tissue, guess what? More scar tissue is coming up. I'm sure you walk around, you see people who have scars, big. These people are forming scar tissue. You look at one person who has his appendix removed, you see a thin line. You look at another person who has the same procedure by the same surgeon, you have a pencil-sized scar tissue over there. So that it's not that the surgeon did anything wrong, the body is creating scar. So surgeons didn't quite understand what was causing the problem. And I think it has to do with, I'm simplifying it, but scar tissue and its creation. So that the answer is not more surgery. The answer is to correct the way the nerves respond to the degenerative disc or the damaged facet or whatever. So that is what got me excited in pain. There was another important thing that happened. We had a good friend who had, he was a professor of mathematics all the way in Nigeria, and he came over to Jamaica because he was dying, came to his brother. And all the hotshot doctors went over to see him. Nobody could stop his pain. This guy was crying in pain. And I said, there must be something that can be done. And that aroused my curiosity into looking at what is happening. So that in the case of this guy, Professor Robinson was his name, he had prostate cancer. But the prostate emits certain substances which cause metastases. By metastasis, which the cancer spreads to distant areas. And this was the cause. Everybody's focusing on the prostate, but he has metastases in his pelvis or in his long bones, in his femur or in his spine. And unless you deal with that, if you're focusing only on the prostate, you miss the point. So it's a question of going back and understanding the disease. This whole concept, I think that's where the cure for cancer will come from. It's the whole concept called angiogenesis, which is to try to understand what in the body affects certain cells and how it does it and what are the consequences of those effects. That is the secret. When we can solve that problem, we'll go a long way, not only to solving pain, but to solving cancer. At least that's one of the techniques.
And as you mentioned it, and that's a question people are asking all the time, how soon are we, how close are we, is there any hope, is there anything that's happening that's hopeful that we can find eventually a cure for cancer?
We're getting better. I'll give you two examples. These are two personal examples. My late wife, Shirley, had multiple myeloma. Multiple myeloma is cancer of the bone marrow. And she was at Vanderbilt. It took them about 3 months to make that diagnosis, but that was way back in 1991. But they did make it, and she got treatment, she got chemotherapy, and she had a bone marrow transplant. She did well for two years, and the cancer came back. When we had the same treatment, it didn't work. She was dead within a year. Today, people with bone marrow cancer or multiple myeloma are living much longer, or some of them are living. I have friends, I have a colleague in Canada who has the same disease, multiple myeloma, and is still alive. So we're making progress. I had a nephew, Orland, who when he was 5, he developed leukemia. We took him up to the States, and the people in the pediatric oncology department told me, Winston, this guy will be dead in 3 months. But there's one option. There's a new drug called donomycin, which they can use. The drug had just been released, just been approved by the FDA, but it had not been used in that hospital. So he told me, what do you recommend? I said, well, I'll put it to my sister and see what she said. She said, Winston, you decide for me. So I said, we'll take a chance, we'll use it. And they used it. The drug cured his leukemia, but the dose they gave was a bit heavy. Of course, they didn't know better. That was the first time they were using it. And although he lived for 15 years, but eventually died at age 19 from the complications of the drug. Now they have more experience. People are living better with this because they have the dose. So medicine, that's why they call it a practice. It's not a perfection. And I think we get in there, we're making progress. So drugs like leukemias, lymphomas, and even things like multiple myeloma, we're making progress with them. There's some new agents coming on the market. I think it'll take some time, but we will still die. All of us are going to die. In fact, the events of last weekend, yes, Easter and Good Friday, lets us know that if Christ died, we are going to die too. But the point is, while we live, we can live relatively comfortably, relatively healthy, and pain-free.
And one final question, Doc. I know not too long ago you were experimenting with our own local medicines and so on. How is that coming on?
Well, because I'm not here, the drug is Philippine. It's available in the supermarkets here. But what I've done, I have partnered with Duke University, and we are expanding it, and we are actually going for. You'll be getting some new developments. We are doing some other. We have changed the drug. We have changed the composition, and we are doing some interesting things. And you will be hearing about it in the future.
We'd like to wish you all the best when you will go to Ho Chi Minh City in Vietnam.
Yes.
And of course, look forward to speaking with you again. All the best and congratulations on your mission to Vietnam.
Thank you very much. Thanks for having me.
This is Our Reality, Calabash TV.